Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hi, and thank you for joining us for episode 2 of the Relapsed Refractory Multiple Myeloma podcast series titled Clinical Viewpoints to Individualize Bispecific Antibody Therapy. My name is Dr. Caitlin Costello. I'm the director of the Multiple Myeloma program at the University of California, San Diego, and I am joined by my friend and colleague, Dr. Joseph Mikhael, the Chief Medical Officer of the International Myeloma Foundation and professor at City of Hope. And at this episode, we're going to be discussing sequencing of bispecific antibodies in relapsed refractory multiple myeloma, but maybe take a step back as well and think about kind of broader opportunities for our patients who are so refractory, whether that's triple class refractory, penta-refractory, and kind of lay out all of our options. And maybe Dr. Mikhael and I will help you understand with all of these options, how can we sequence them? How can we organize them in ways that are going to just prove to be the most effective and most safe for our patients? So perhaps, Joe, will start off and think about a couple of different scenarios for these patients. We have, your average triple class refractory or penta-refractory myeloma patient, and we are kind of at a point where they've had 4 prior lines of therapy. And we have previously in podcast 1 talked about how we may choose a bispecific versus a CAR T cell therapy. What if now you have a patient who has an option for either? We said before, perhaps if they had very aggressive disease, we would kind of lean towards bispecific. But we also mentioned you have a couple of different targets at your disposal. Let's think about this a little bit. If you have a GPRC5D bispecific, you have a BCMA targeted bispecific antibody, and you have a CAR T cell therapy available for your triple class refractory patient, why would you choose BCMA over GPR, or would you choose CAR T over bispecific? I'd love to hear your thoughts.
Yeah, of course. So you always ask me the tough questions too, I must say, but no, these are great. I mean, I always start the kind of answer to a question like this to say it's good to have choice, because it's not such that one of the 3 is so much better than the other 2 that you have to choose it. So it is always great to know that we have choice, and that choice depends on a lot of factors, as you've often outlined before. The patient factors, meaning what is their preference, what are their comorbidities, what is their clinical scenario, the disease itself, is it rapidly growing, is it slow growing, is it higher risk, is it more standard risk, and then of course the therapy themselves, what potential toxicities are we going to be looking at. And I think when you try and distinguish between those 3, CAR T, BCMA directed bispecifics or GPRC5D bispecifics, there may be certain things that really push you one to the other. Like we discussed in episode 1, that if you have very rapidly growing disease, I might favor going to a bispecific. I think if none of those things are tipping my hand one way or the other, or the toxicities, don't necessarily push me or pull me away to any of the 3, I generally speaking tend to favor CAR T, only because we do have a little bit longer term data with them. We have a bit of a higher response rate, but we also do have to accept greater toxicity in the short term and the potential for long term. Some of the longer term neurotoxicities, I don't want to overemphasize them, but I also don't want to underemphasize them. We do have some patients that really struggle in the long run. Thankfully, I think the number is shrinking, and it's very rare now, less than 1%. But we do have some patients that have this really quite dramatic Parkinsonian-like neurotoxicity in the long run that we haven't fully understood yet. So having that conversation with the patient, walking them through it. The second reason why I tend to favor a little bit of the CAR T is also just from a sequencing standpoint. In my mind, if I can sort of overload them with these T cells up front and then give their T cells a rest for a while before later introducing a bispecific, that might be a natural sequence, as opposed to using a bispecific. And then we know sometimes if someone's actively on a bispecific, it may be a little bit harder to collect their T cells for a CAR T. But that being said, I really think all 3 options are very good options. And maybe my last point here, Caitlin, is that if someone has had a BCMA-directed therapy, whether it was CAR T or bispecific, or potentially if they had belantamab, and I'm thinking also into the future that we'll likely have belantamab back to us, that might be time for me to do a class or to a target switch to switch over to a GPRC5D directed therapy.
You brought us right to the next question there, which is to say, how do you choose which target first? I mean, I think we have quite a few options for BCMA targeting. We have those 2 bispecifics and 1 CAR T, and then 1, as it stands right now, at least approved GPRC5D targeted therapy with that bispecific talquetamab. So is there something that would make you lean towards choosing to target GPR first or BCMA first? Is it just come down to a numbers game? How would you kind of approach that?
You mean apart from just asking you? I do think that I think it is tricky. I think in general we have gone more towards BCMA before GPRC5D for a couple of reasons. One, again, we just have longer term, more data, more options, as you've mentioned. Number 2, I think we all realize that the toxicity from GPRC5D therapy is a bit unique and is a little bit different, where we don't just classically see the CRS and neurological toxicities and infections. We have these other off-target effects because GPRC5D is expressed, in our hair and our skin and our nails and in our taste buds. And so patients do get, loss of taste. They can lose some hair. They can get significant changes to their nails. And not that those are impossible or intolerable, but we are still figuring them out, to be very honest. And I think we will get better at managing them. And so if I'm looking at those 2 potential options of BCMA-directed therapy or GPRC5D, from a toxicity standpoint, I may want to delay the GPRC5D approach. But again, I'm not sure those are rock solid. Obviously, with the discussion of the patient, it could be either way. But that's why historically I've slightly favored going towards a BCMA approach prior to the GPRC5D approach.
I think that makes sense because with more BCMA targeted therapies than GPR, it opens up this opportunity to start, for example, as you mentioned, with the CAR T first and do a BCMA targeted CAR T cell therapy and get some longevity out of that, right? Really trying to hope we can get a durable remission, right? We've seen cilta-cel be close to 3 years for that, heavily pretreated patient in terms of progression-free survival. And after those, hopefully, years of having those T cells kind of get some time to rest, then we can really put them to work. And, I suppose at that point you can decide, do you want to do a BCMA targeted or a GPR targeted bispecific? But I think that's where the bispecific comes in next, because remember, just like we talked about in podcast 1, those weekly, initially at least, step-up dosing followed by weekly dosing and hopefully spreading it out thereafter really does put a lot of pressure on those T cells to kind of go to work, if you will. And maybe that's a good opportunity to switch your target from that BCMA CAR T to GPR bispecific, and then still come back again with the BCMA bispecific after the patient has perhaps progressed on the GPR bispecific, if we think those T cells obviously still have some kind of juice or time left in there. You brought it up, Joe, so I'm curious. We've learned a lot about kind of novel drugs having novel toxicities and what we're learning about how we're going to manage GPRC5D and those side effects. And it brings me back to the new side effect of, that we learned about belantamab. And as you mentioned, belantamab and, the notorious eye toxicity associated with it was what led to its removal from the market. And we've had lots of data recently showing some very positive outcomes with belantamab and perhaps its eventual, as you mentioned, reintroduction back to the market. So if that BCMA targeted antibody drug conjugate comes back, where do you place that in sequencing? What kind of niche do you see?
Yeah, no, I think it's a very legitimate question because I do think the data was convincing. I do think it will come back. And I think thankfully it just adds to the same dimension we've discussed, that there is more choice for patients. I'm not sure it'll have its own little niche. I think actually could have quite a broad effect. One of the real draws to belantamab compared to all the other therapies we've discussed today is just its ease of administration. I mean, this is given over a half an hour. It's given, I think, much less frequently than the trials were done. That's how I think we're going to mitigate the toxicity. I mean, I still have a lot of patients on belantamab. I plan essentially to give the dose once every 12 weeks, and sometimes it's even less frequent. And outside of the eye toxicity that you've mentioned, which I think we're getting better at managing, there are very few other things. We really don't see CRS. We don't see neurological issues. We don't see. So I could see it being a lot more easily administered out in the community in places that are considerably far away from a center that has experience giving CAR T or bispecifics. The older, more frail patients where it may be a bit of a concern to introduce the therapies that we've discussed with respect to infection risk or neurological risk. So I think it will have a place there. But I think the last point I'll make that is very important that you've beautifully just described is that you don't just get one kick at the BCMA can, if I could put it that way, that I really do believe as we sequence these things better, we can go back to it. The BCMA target is very unique. It's not that it completely disappears after treatment like we might see with CD38 for a period of time. So I do think we will be in a strategy with times where people will see more than one BCMA-directed therapy. This is part of the work, of course, we do in my research lab, and we're understanding this better. So it's not like it's going to have just that one option at one point in time. I think it will be integrated into our larger sequencing approach.
I think one of the neat things that the DREAM studies, this is DREAM 7 and DREAM 8, did for us was it really showed us how we could combine BCMA targeted therapies with our kind of usual suspects, as you will. And, those DREAM and 7-8 studies looked at belantamab in combination with bortezomib index or belantamab in combination with pomalidomide index. And, I think we've been very excited to see single agent responses with our bispecifics or our CAR T as examples, but it really does open up the door next to say, how could we potentially combine our bispecifics as an example with some of our usual suspects? And we learned a little bit at ASH last year about combining talquetamab, for example, that GPR bispecific antibody with pomalidomide index. I'm curious, where do you see the field of kind of combinations with our bispecific antibodies heading?
Yeah, I actually think it's a controversial topic because although we did see the benefit when we combined teclistamab and talquetamab in that study that you mentioned, the redirect study, and yes, the response rate went higher than the typical sort of 2/3 to 3/4 of patients responding that we'd seen before. It did come with extra toxicity. And I'm a little nervous about us going into these doublets, triplets, quadruplets like we're using with some of our other drugs, just because of how profoundly these drugs work, but also because of the immunosuppression that comes with them. Now, maybe this will help a lot as we use them less frequently. As I've intimated before, I don't think we can or should be giving these drugs weekly indefinitely. And in fact, there are others in development that, even from the very start, are given once monthly. But I do think it is important to study this because we've learned that one drug can't really hold down myeloma. Myeloma is a complicated disease with a multi-headed biology that seems to have to be treated with a multi-headed approach. It's kind of like we mostly overcame HIV, not with one drug, but with the right combination. So I do think it's natural that we study these combinations. I think we just have to be very careful that we keep a close eye on toxicity as we do so. And I think inevitably, as we move these drugs into earlier line therapy, we will be using them in combination. And of course, we even know there's studies looking at putting them in combination with CAR T, giving that big dose of T cells and then possibly maintaining that response with intermittent bispecific therapy. That's something that I'm interested in because I think biologically it makes sense that if relapse after CAR T occurs because the T cells run out of gas, if I can say it, then maybe we could just keep refilling the tank or keep, let's use it in good electronic vehicle terms. Maybe we just make sure we plug it in and recharge it every once in a while so that we can keep that car going.
You bring up such important points of, how much we still need to learn here. I think we've been so excited about the outcomes that we've seen, bispecific antibodies have with our very refractory population. And if I can argue, I think many of those patients are willing to do whatever it takes to get a response and to get into remission. And I wonder how that will translate, as you mentioned, with some of these toxicities, which really can affect quality of life pretty significantly. Now, on the one hand, I can make the argument that using bispecific therapies, when you have those nice, fresh, robust T cells kind of in that newly diagnosed setting or early relapse, those T cells haven't had the kind of time to be beat down like we usually do to them over time with all the steroids and all the drugs that we use. Perhaps from a biologic perspective, it makes great sense to use T cells therapy or T cell redirecting therapy of whatever we're using, early on in the process. But you're right, we have to figure out how to kind of balance the quality of life effects that it may accompany it as we figure out how to manage the mouth and the skin and the nails and the hair side effects. So I'm excited for it, but I agree. I'm cautiously optimistic about it. And I think it's important to recognize that, patients who are diagnosed with myeloma, right, on average are in their mid 60s or so. And although we have some outliers of older or younger patients, comorbidities and toxicity tolerance are going to be very different amongst those different groups. And we've really enjoyed, as we transition this conversation a little bit into newly diagnosed and early relapse. I mean, we've been so spoiled by the Maya data that tells us how wonderful daratumumab and lenalidomide and dexamethasone are, and how well tolerated it is and how effective it is both with PFS and OS advantage. Like, can it get any better? Should we be treating our older patients with bispecifics up front? Is this feasible to treat our frailest patients? What do you think?
Well, we don't really know the answer till we try. But I think what you just said is really the essence of the discussion. As we move any therapy, but in particular therapies like bispecifics that have both been very effective, but also do carry toxicity, as we move them earlier on into therapy, as early as first relapse to frontline to maybe even smoldering myeloma where this is being investigated, the way I try to describe it, Caitlin, is that the bar has to be set so much higher for both efficacy and toxicity. Right? So when a patient has had myeloma for several years and has been through multiple lines of therapy, just being very pragmatic, there is a greater acceptance and understanding of certain toxicities. We just know that as the disease has progressed, we have to accept amount of toxicity. I'm not willing to have that same amount of acceptance in frontline therapy or even at first relapse with the great options that we have. And I think that's even coloring a little bit of our discussion about bringing CAR T much earlier, is that we want to ensure it's safer when we do so. So as you said, with Maya and perhaps most recently with IMROZ, even going to quadruplets in frontline therapy in patients who are ineligible and eligible for transplant, we're seeing response rates well over 90% and often durable for many years. So only if bispecifics can exceed that high bar will it be reasonable to consider them from efficacy and indeed from the toxicity standpoint. So I think the myeloma community has that sort of built into the process to make sure that it's not just, it worked later, so let's use it earlier without rationale. Let's make sure that the bar is set so high that we're very meticulous in ensuring that these patients benefit from something that is brought so much earlier in the disease course.
Thank you for summarizing that. And if I can be so bold as to kind of harken back to something you mentioned just there and maybe put you on the spot a little bit, I can't imagine a more controversial topic in kind of multiple myeloma than the treatment of smoldering myeloma, or do I even dare say the quote treatment of MGUS, monoclonal gammopathy of undetermined significance. Well, you said it. There are trials here looking at a variety of different treatments for these disease states. What do you see the future of treatment for high-risk MGUS or smoldering myeloma to be, and to potentially include these T-cell redirecting therapies?
Yeah, that's a tough one to ask me at the end of the podcast, but let me put it this way, that we have to remember our first adage in medicine: above all, do no harm. And whether it's low risk smoldering or even high risk MGUS, the vast majority of those patients are going to do well with the current standard of care, which is nothing. And so we have to be very careful that if we're going to introduce a therapy, that there really is going to be a difference. I don't really ever see a day where we're truly treating MGUS, maybe with nutritional interventions and things that are really quite benign that could have a benefit in other aspects of people's lives, but of something as medicinal as a bispecific antibody, I'm not sure. I do think it's important to study it so we can understand it better. That being said, I do think in the high-risk smoldering world, we're redefining myeloma all the time. And we all know myeloma is myeloma. So some of these patients, maybe they don't meet our current 7 criteria for a myeloma defining event, but they're so close to it. So I do think that when T cells are less beaten down by previous treatment, when people's immune systems are stronger, I think there may well be a very strong rationale for using this earlier in the treatment course, especially as we work out some of these toxicities and optimal management of these patients so that it can be even safer and more effective.
That was a perfect answer, as always. I think, Joe, we are learning so much about all these drugs and who the best ideal patients are. And as we see new drugs come to market and development of, new therapeutics with novel antigens, I think the horizon is just so bright. So thanks for taking the time to think this through with me and help us kind of understand, of our plethora of options, how we can best serve our patients. So I thank you for being here with me today, and I thank all of you for joining us for episode 2, and hope you enjoyed this series.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.